Welcome to CardioCast for Friday, October the 11th. I'm Dr. Jim Dwyer. This week, preemptive TAVR may not be needed for type A aortic dissections. TAVR and SAVR share the same infective endocarditis risk, and why moderate aortic stenosis may be just as deadly as its severe sibling. But first, researchers in Scotland are aiming to solve a thorny emergency department problem: how to rapidly determine if a patient is having an acute myocardial infarction without sacrificing patient safety. Dr. Nicholas Mills is the chair of cardiology at the University of Edinburgh, and he led the HISTORIC study. That's short for high sensitivity cardiac troponin at presentation to rule out myocardial infarction. The study compared two approaches. The first is the standard of care, which uses high-sensitivity cardiac troponin I testing at presentation and again in 6 to 12 hours. MI is ruled out if the troponin levels aren't above the 99th percentile. The experimental approach involves early rule-out. Dr. Mills explains.
The high-stakes pathway is easy for clinicians to use. The adherence to the pathway across 7 hospitals, many hundreds of different clinicians during the trial, was over 92%. Simple and pragmatic. If your concentration is below our low-risk threshold, a single test is all that's required. If it's above the 99th centile, the diagnostic threshold, then patients require admission for hospital in order to understand what the mechanism of injury is. And that small group in the middle require a second test in the emergency department to make sure that troponin concentrations are not increasing. So we have, I think, distilled the power of the test into a simple algorithm that clinicians seem to follow carefully.
In the 2-year study, the new approach reduced the length of stay in the emergency department by 3 hours, and it increased the number of patients discharged directly from the emergency department. But does it meet the safety threshold?
We followed up all patients for 1 year for a primary safety outcome of myocardial infarction or cardiac death following discharge from hospital, and found no evidence of harm associated with implementing this pathway.
The new approach also has a lot of potential for cost savings. Researchers said by reducing length of stay in the emergency department by 3 hours, the new approach could potentially save more than $3 billion a year in bed occupancy alone. Preemptive thoracic endovascular aortic repair after acute aortic repair may deliver no benefit to patients with extended type A dissections, at least in the midterm. That's according to results reported by Dr. Amy Reed of the University of Minnesota at the annual meeting of the Midwestern Vascular Surgery Society. Their study evaluated 87 consecutive patients from 2011 to 2018. 43 had extended type A dissections and 44 had type B dissections. Dr. Reed and colleagues hypothesized that after initial repair of the ascending aorta, extended type A and type B aortic dissection would see similar dissection growth rates. And the researchers predicted there would be a similar need for more intervention in the descending thoracic aorta. But that was not the case. Instead, when the investigators looked at intervention-free survival, they found that significantly more type B patients required intervention. After 9 months, only 35% of type B patients were still intervention-free. At 28 months, however, 88% of extended type A patients remained intervention-free. We'll be right back after this message. The risk of infective endocarditis after TAVR to treat severe aortic stenosis proved to be the same as after surgical aortic valve replacement. That's the key finding from a French study that may be the largest ever look at infective endocarditis following TAVR, and it will come as a surprise to many physicians. Dr. Laurent Fauchier of François Rabelais University in Tours, France, presented the research at the annual Congress of the European Society of Cardiology. He says it's easy to mistakenly assume that the risk of the feared complication is lower and perhaps even negligible in TAVR patients. After all, the procedure does not involve a significant surgical wound, and it's briefer with a shorter hospital length of stay than SAVR. But Dr. Faucier warns the risk of infective endocarditis is all too real. He outlined the findings from his study of nearly 108,000 patients who underwent isolated TAVR or SAVR in France during 2010 to 2018. The researchers adjusted for the reality that the TAVR patients were overall markedly older and sicker than the SAVR patients. The rate of hospital admission for infective endocarditis was 1.9% per year in the TAVR group, very similar to the 1.7% per year rate in the SAVR cohort. And all-cause mortality in TAVR patients who developed infective endocarditis was 32% greater than it was in the SAVR patients with infective endocarditis. Dr. Faucier's takeaway: be aware, be careful, and provide appropriate antibiotic prophylaxis, just as surgeons do in SAVR. And remember, the TAVR valve is a device, it's a prosthesis, and the risk is very similar to that of surgery. The 5-year mortality rate associated with untreated moderate aortic stenosis is just as grim as it is for severe aortic stenosis, according to new findings from the largest ever study of the natural history of aortic stenosis. Dr. Jeff Strange presented the stark message at the annual Congress of the European Society of Cardiology. Dr. Strange is a professor of medicine at the University of Notre Dame in Fremantle, Australia. He says the data provide a clear signal of the expected adverse outcomes for patients with a mean aortic valve gradient greater than 20 millimeters of mercury or a peak aortic valve velocity above 3 meters per second. Dr. Strange and his co-investigators analyzed echocardiographic data on nearly 26,000 Australian patients with untreated mild, moderate, or severe native valve AS. They found that the 5-year all-cause mortality rate of 61% in the group with moderate AS wasn't significantly different from the 65% rate in those with severe AS. In particular, the researchers noted that both all-cause and cardiovascular-specific mortality rates were basically flat until they took what Dr. Strange described as a sharp pivot point upward, right around 20 millimeters of mercury or 3 meters per second. If other analyses confirm the findings, Dr. Strange predicts the results could have enormous implications for the use of transcatheter and surgical aortic valve replacement, interventions that until now have been restricted to patients with severe aortic stenosis. And that's it for this week's edition of CardioCast. You can find these stories and more by visiting www.mdedge.com/cardiology or by clicking the links in the podcast notes. This week's contributors include Bruce Jansen and Richard Mark Kirkner, and CardioCast, Cardiology News, and MDedge Cardiology are edited by Catherine Hackett. Remember, you can find CardioCast via Amazon Alexa, Apple Podcasts, Pandora, or wherever you listen to podcasts. And if you like what you hear, please leave us a rating or review. For MDedge, I'm Dr. Jim Dwyer.